Welcome everyone to our webinar today, Pharmacy Staffing Models that Drive Cost Savings, Clinical Programs, and Improve Patient Safety. I'm Emily Rapley with Becker's Hospital Review. We will begin the webinar today with a presentation, and we will have time at the end of the hour for a question and answer session. You can submit any questions you may have throughout the webinar by typing them into the Q&A box on your screen. We look forward to hearing your questions. Please note that today's session is being recorded and will be available after the event. To access the recording, use the same link you used to log in today. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Mike Culligan is a graduate of the University of Connecticut and has worked as a clinical pharmacist in several states. He has been the Director of Pharmacy at St. Francis Hospital and Medical Center since 2000. Mike has been an active contributor and leader on many of the hospital committees with a focus on enhancing quality of patient care. He's assisted in the expansion of clinical pharmacy services into the emergency room, operating rooms, and ambulatory care, and worked to include antimicrobial stewardship. He also serves as a preceptor for the postgraduate Year 1 Pharmacy Management Leadership Rotation and recently completed a Healthcare Leadership Fellowship in 2018. Mike is joined today by Kelly Morrison, who is an industry expert on innovating pharmacy productivity and workflows in multiple care settings, including acute care, ambulatory care, and retail. As Director of Remote and Retail Pharmacy Services for Cardinal Health, she leads the nation's largest remote pharmacy services business, Hospital Outpatient Pharmacy Services, as well as Central Fill and Community Health Center pharmacy businesses. Kelly's 24-year healthcare career includes co-developing the first national remote medication order processing service in 2003, in addition to the development of proprietary technology to enable the service that is now used by over 600 hospitals today. Kelly co-authored the American Society of Health System Pharmacists Guidelines on Remote Medication Order Processing and presents this topic at professional meetings on a national platform. In addition, she regularly presents to state boards of pharmacy to advocate on behalf of licensure requirements for telepharmacy and remote pharmacy models that enable the critical expansion of clinical pharmacy services to improve patient care. At this time, I am pleased to turn the floor over to Kelly to begin today's presentation.
Thank you, Emily, and I'd like to thank all of the participants for joining our webinar today and look forward to your questions following our presentation. On our call today, we will discuss some key industry trends that are creating challenges to traditional pharmacy staffing models, and then hear from Mike, who will share his experience with specific challenges that his health system faced and how he and his team approached it, evaluated potential solutions, and developed a business case to actually justify implementing an alternative staffing solution. Mike will also share post-implementation results that align back to the business case, in addition to unexpected or even less measurable benefits that his health system realized as well. Lastly, Mike and I will provide tips on building an effective business case that focuses on key metrics that tend to resonate with executive leadership. So let's get started on what are some of the trends that the hospitals out there and health system leaders are seeing today. Doing more with less is nothing new. This has been going on for several years now, in addition to personnel and project budgets being flat despite growing hospital administration expectations. And although health systems always focused on key areas, right, quality, cost savings, patient satisfaction, with the reimbursement shifting to value-based care, additional initiatives are now critical in order to minimize the impact of the reimbursement changes to our health systems. So as we look at programs around improving quality or driving cost savings and increasing patient satisfaction, reducing unnecessary readmissions, and even providing transitions to care programs, a lot of new initiatives are being developed that, again, pharmacies weren't involved with in the past. Initiatives such as antibiotic and pain stewardship programs, med utilization initiatives, and the complexity of trying to manage high-cost specialty drugs, looking at trying to manage an effective processing turnaround time to ensure patients are getting the correct medications in a timely fashion, looking at how we can improve patient satisfaction also through discharge counseling, getting our pharmacists to be necessary and critical components of the patient care teams, looking at meds-to-beds programs as a form of trying to improve adherence once the patients are discharged from the hospitals, medication reconciliation, whether it's reconciling the patient's medication list upon admission and or reconciling it then again as they're being discharged into either a long-term care setting, behavioral health setting, rehab, or even back into the community. Many health systems are looking to implement a retail pharmacy within their hospital as a way to actually, again, continue to support some of the post-discharge initiatives. They look at this as potentially creating a new revenue stream and even looking at it as a solution to potentially reduce employee benefit costs. And if we think about all of these programs, the key leaders and the key resources that are involved not only to develop them, but also execute and maintain them are all clinical pharmacists. And again, this is something that in the past, while clinical pharmacists were all very involved, whether it was quality, safety, patient satisfaction, and drug cost savings, these are now new initiatives that are on the horizon that they're being asked to do in addition to everything that they're already doing today. So clearly, demands on the pharmacist's time are increasing. And amidst the landscape with many new initiatives, they still have to maintain everything that they were doing before and all the service levels and support that they provided the hospital even prior to all of these landscape changes. So in addition to a lot of the initiatives we just discussed that pharmacists are being asked to lead, they still have increasing time spent on regulatory compliance, looking at managing supply chain, and even consolidation change management. We're seeing healthcare consolidation on the rise, and it continues to be, and we don't see it slowing down, where a lot of the smaller rural hospitals are actually being consolidated into the larger health systems. So even despite all the other initiatives that we just discussed, one large initiative that results in consolidation is just looking at how you can create standards and truly integrating those hospitals in a timely manner without impacting safety. Pharmacists are struggling to find time to collaborate with the medical staff and counsel patients. That is such a necessary piece of, again, increasing and improving HCAHPS scores, improving med adherence, and reducing readmission rates. They have minimal time to focus on quality patient and clinical outcomes because, again, they spend too much time looking at just administrative tasks that need to be done. Amidst all these different changes, again, what it results in really is just less time and pharmacy leaders being able to develop a proactive workload balanced pharmacy staffing model. A lot of these pharmacies are large pharmacies and historically have had adequate staff to balance all the priorities that pharmacy is faced with. But amidst all these new changes and new needs that are being an absolute requirement of the hospitals and healthcare leaders, pharmacy now is struggling to determine how do they actually provide adequate pharmacy resources to effectively implement and execute all the needs that are, required throughout the hospital. They have less time to develop and execute the initiatives because they're just trying to keep up with what's already in place. And again, remember, the obvious answer in addressing a lot of these challenges is simply add more FTEs, increase your overall pharmacy staff. But unfortunately, as we discussed even on the prior slide, that in many, many cases, personnel and FTE budgets are flat. And so again, pharmacy leaders have resulted to try to look at what are some alternative or creative staffing models, may look a little different to the historical traditional models, that will enable them the time and resources to not only develop these initiatives, but execute them successfully. With that, I'd like to turn it over to Mike, and so he can talk about some specific challenges that his health system faced and how they went through evaluating different approaches, developing a business case, and then looking at the results 1 year forward. Mike?
Well, thank you, Kelly, and thank you, everybody, for joining the call, and good afternoon. So just a little bit of a level setting about St. Francis Hospital Medical Center. So we are currently located in Hartford, Connecticut. We're a 617-bed acute care teaching hospital that also has a 50-bed chronic disease rehabilitation hospital attached to it. A little bit about the pharmacy specifically. So we have what I describe as an integrated pharmacy model. We have pharmacists integrated throughout both the inpatient and the ambulatory setting. We have a relatively large array of technology at St. Francis related to medication management. Some things specifically, we have been a longstanding Epic hospital. We were an early adopter of IV workflow technology. We currently use DoseEdge. We use MedMine for our stewardship and our data mining and interventions. We were also an early adopter of KitCheck to help manage our code trays and our drugs in the operating room. We've had carousels and bedside barcoding for a long standing, and we've had Pyxis for a long time. So just sort of level set. We also have a PGY1 general residency program, as Kelly alluded to earlier, and we also have a PGY2 in ambulatory pharmacy. So just sort of set the stage. Similar to what Kelly said, we were a long-standing single entity for about 130 years, and in 2015 we joined a large IDN, Trinity Health, which is approximately 94 hospital system, scattered amongst 22 to 23 states all over the United States. In addition, Trinity is kind of set up as what they refer to as regional health ministries. So those 94 hospitals are broken up into other entities. We're a new entity called Trinity Health in New England, and in 2016, in our market, we acquired Johnson Memorial Medical Center, which is a 70-bed acute care rural hospital, which is pertinent to this because they were using remote services prior to us. So a little bit about our challenges, as Kelly alluded to, we're all facing healthcare challenges, and specifically here in the pharmacy. And to execute and try to fix some of those challenges we had, my leadership team and I had put together a pharmacy strategic plan and vision in 2017 and 2018. And elements of that plan that are pertinent to our topic today was dramatic expansion of a lot of our inpatient clinical pharmacy services. So we really wanted to be the best, and we wanted to execute on expansion of stewardship, expansion of clinical and consult service and dosing services. We wanted to expand our ability to really improve the cost of care. And as we were executing the early stages of our strategic plan, it became extremely apparent, and now that I look at it in retrospect, it's amazing we sort of lasted this long, that our third shift capacity was really holding us back from being able to execute many of these clinical strategies, because our goal was to provide these services 24/7. We wanted to provide excellent care for all of our patients 24/7 every day, and as you can see on the slide here, we were covering about 670 beds, and from 11:30 at night to 6:30 in the morning, we had one pharmacist and two technicians. And you can imagine at a big, large academic center, that's pretty small staffing, and we really couldn't ask them to kind of take on any additional responsibilities or clinical responsibilities. So once we kind of got there, this became our burning platform and strategy priority number one to fix. And it was kind of the first thing we needed to solve for our strategy. So as Kelly alluded to, I have a pharmacy leadership and administrative rotation with all of our general residents. And as soon as this became our burning platform, I required them all to do a business plan in my rotation, and this was the assignment of our resident to put together this business plan. So as we were putting together this business plan, and it was primarily our resident doing the work, but we were partners along the way, it was, our initial goals here were to hire. We have a third shift of 7 on, 7 off, probably as many. So that one pharmacist is 7 on, 7 off. And our goal was to go to 2 pharmacists, 7 on, 7 off. And as you can imagine, third shift pharmacists are relatively expensive. And it's also, they're not easy to find. And also, it takes a long time to train, because the people that are generally attracted, and at least in my experience, to those positions are relatively the newer pharmacists. And in a large academic medical center with a lot of complexity and a high CMI, the training requirements were going to be great. So we needed to actually come up with an alternative plan. So the 2 reasons why we needed the alternative plan is we actually missed our budget cycle. So we run on a July 1 to June 30th budget cycle, and this burning platform was after our year's budget. And in addition, even if we're going to execute the 2 FTE strategy, we felt like the onboarding process was going to be quite extensive. So we changed our ideas just a little bit. So we came up with really an alternative plan. And the initial plan was to bring on board remote pharmacy services and have that in place for 1 year, and then transition it to becoming our own staffing. So the keys to, I guess, that business plan, and I can't stress this enough, that the biggest key for success in the beginning of building this business case was the benchmarking. And this isn't quite as formal benchmarking as maybe some of you know, and using other things like Solution, and we use iVantage now within Trinity Health, and benchmarking yourself. This was a little more informal. So what we did is we went and used similar like-sized facilities across the country that were willing to share with us their staffing models for third shift. We actually used some of the retail pharmacy staffing models and processing prescriptions. And then also we actually leveraged the remote services, people in that space to look at how they do their staffing models. And what we found, which was extremely glaring, that pretty much everywhere we looked, we were double the norm. We were on the wrong side of the bell curve. So meaning that our pharmacists on third shift were processing 2 times what we found as the average. And you can imagine going to senior leadership with a business plan when you're that far out of the norm. They're going to take notice, especially with all the the safety things that have occurred across our nation for the last couple of years. Other extremely key components, though, is what were going to be the benefits of this additional resource. So we focused primarily on safety, and what those benefits that we felt were going to be is dramatically reduced turnaround time. So what we had done is we had looked at about 6 months of data for our third shift, and we could see where we had really delayed turnaround times. And there were pockets where we're really not meeting the needs of our customers. And you can imagine on third shift, your biggest customer, at least our biggest customer, is our emergency department. So our emergency department is about 95,000 ED visits a year, so it's a busy ED, and there were pockets of time where we were not meeting their needs. In addition, because of the delays in verification, we had an overabundance, or I wouldn't say overabundance, but higher amount of nursing overrides than really we wanted. We were still below the national norm, but we expected it to be lower. Also, we had done a couple of MUEs over the years on high-cost ED drugs. Specifically, one I'll highlight for this talk is Concentra. And because of the nature and the busyness of our third shift, our pharmacists did not have enough time to vet the quality and the content of those orders enough to intervene. So they were processing them with minimal information because of the nature of the busyness. So we felt there was going to be a tremendous cost savings on providing additional resources. So if you can imagine our business plan, it took on benchmarking, which showed that we were about 2 times the norm. We highlighted the safety benefits that were going to impact our stakeholders, nursing and physicians, and there was going to be a financial return on investment for doing this. So we kind of felt like it was a win-win, and whenever we develop a business plan, we try to get grassroots support before we take this to senior leadership. So what did this look like a year later? The one thing that I will highlight, the plan that we put in place was a FTE model. For some of you who are familiar with remote services, there is 2 potential models. One where it's, you're paying by orders, and one where you've kind of got a dedicated staff, and they're just like you, they're providing basically that resource for a period of time. So that's the direction that we went. And in analyzing all of our data, our weekends were not busy enough, and our third shift pharmacists felt like we needed the resources on Monday through Fridays, weekdays. So a year later, what did this look like? We demonstrated a 40% improvement or reduction in our order verification turnaround times. I would liken that also to some of our, compounding turnaround times, because our on-site pharmacists can verify the IV preparations a bit quicker also. We saw a dramatic decrease in nursing overrides, and we saw a tremendous improvement in the quality, in the content of how they were verifying the more challenging orders. So they were intervening a lot more on stewardship, especially out of the emergency room or the ICUs on overnights. We saw a much better improvement to our clinical indications on Concentra. There was definitely some cost savings there. And we just saw an overall improvement in the overall documentation of interventions from our third shift pharmacists. So in addition, didn't advance it. So some things that were a little bit less unexpected. So those ones that I highlighted earlier, we kind of expected those. Those were the things that were built into the business plan. The other things not expected were our partners in remote services were very flexible in adjusting their times that they could provide service to us. So if we ever had, censuses through the roof, they could help with additional time. We never even thought about coverage on holidays and tweaking those times, so they can do that. We also found into the program that initially we had 5 days a week, and we found that our Sunday nights into early Monday, our ORs were cranking, and that Monday morning early was too overwhelming for our one pharmacist. So we were able to adjust our schedules and make changes relatively quickly, which was a significantly added benefit. The other thing I feel that was totally kind of unexpected but hoped for was the tremendous improvement we have had in employee engagement, I would say, and satisfaction. So one of the things I think was critical to our success was this wasn't pharmacy management doing it to the third shift team. Our third shift team was part of this process all along the way. In the beginning with the onboarding, in the beginning with implementation, and part of our assessment of our quality calls. So all along the way, they were a partner and engaged in improving and making this a successful service. So for some of you that do employee engagement, you may be familiar with this, but we use Press-Ganey for our employee engagement. So there's a 3-tier, tier 3 being the worst, tier 2 being in the middle, and tier 1 being optimal. So I believe part of our success of going from a tier 2 to a tier 1 on our employee engagement was this program. I think it showed faith in our staff that pharmacy management cared about them, honestly, and also was able to execute a strategy that was successful, and I think that provided them dramatic satisfaction. The other, we had occasional complaints previous to our remote services from our ED about delays in verification and patient care, and we haven't had any really since. And anecdotally, in talking with them, they have seen dramatic improvements there. And the other thing that was key is we use Tiger Texting as our secure texting platform here at St. Francis. We'll probably be going to the Epic texting here in the future. But that is our current platform, and the remote services pharmacists were added to that platform about halfway through our year. And that has dramatically improved the collaboration, communication, and I actually think has changed the culture on both sides. I think our goal is our remote service partners are part of our team. We want them to feel part of our team, just as if they were on site here. And I think being able to communicate regularly in an easy fashion has significantly improved both the quality and the engagement of both the St. Francis team and the Cardinal team. So I think, Kelly, you were going to touch base on the beginning of this slide.
Sure. Thanks, Mike. So as we think about creating your case for change, three key areas that I know Mike and his team looked at are really pretty common as we work with healthcare leaders across the country and looking at helping them build those business cases so that they can look at alternative staffing models when necessary. Again, focusing on patient safety and the financial impact tend to really resonate with the key executives, and then really analyzing the impact of resources and potential missed opportunities from clinical programs and drug savings. It's not really just good enough oftentimes to show, here's how we think that this will improve safety, and here's the labor savings, which labor savings is always kind of a basic component, but looking at all the cost avoidance that could be associated by reduction in preventable adverse drug events, for example, because you have adequate pharmacy staff making sure they're prospectively clinically reviewing all medication orders 24 hours a day with a consistent continuity of care. And then benchmarking and comparing similar hospitals and even including their ambulatory care or retail environment if they have it. And that was really effective approach that Mike and his team took, because without doing that, it's really hard to prove to senior leadership or executive leadership why you might need additional resources. You already had staff in Mike's case on the third shift, and so by him showing that the staff they had was already doing twice what the average, benchmark is from a productivity perspective, that really went a long way in justifying that, how it was going to be critical in leveraging additional headcount to supplement them, because it was going to be pretty difficult for them to expand those clinical programs on the third shift and maintain the productivity standard that they had already set that was really, really high. Some other kind of key metrics that we see a lot of hospitals look at as, again, they go back and looking at how can they get additional staffing, and again, whether it's bringing on FTEs or looking at more of a hybrid or blended approach like Mike and his team did, and leveraging, kind of a combination of on-site and off-site resources. Again, labor savings is one of the most, definitive returns on investment metrics that you can show to your CFO and senior leadership, but don't minimize looking at cost avoidance through the reduction of preventable adverse drug events, because you do and will have adequate pharmacy staff to be actively involved at the time the physicians are writing the orders for the patients. Pharmacists actively involved at the time the patient's being discharged, so that they can look through the patient's list of medications almost in a, just before post-discharge med rec list, and ensure there aren't duplicate therapies, and that in fact the patient is on the right discharge meds, and that those meds they can easily get through their insurance and reimbursement programs. Looking at turnaround times, which was a key metric that I know Mike and his team looked at and were incredibly sensitive to, because even prior to the additional help, he had mentioned there were some satisfaction issues and some missed opportunities even in the emergency department from being able to provide pharmacist support timely. And so don't minimize the importance of being able to reduce or improve pharmacist turnaround time and processing those orders. Decreased nursing overrides is also a really great metric. And oftentimes when you've got larger health systems or hospitals that do have pharmacy coverage 24 hours a day, 7 days a week, that doesn't necessarily equate to nursing overrides being at a low percentage of the total dispenses. And so Mike and his team actually looked at that. Again, they had pharmacy staff there 24 hours a day, but by getting the additional resources that they need, and again, processing orders in a more timely manner, he saw a significant reduction in those overrides, of course, then boosting and improving safety. Looking at drug costs per adjusted patient day and antibiotic savings, we've had several health systems that we worked with, and one of the things they were most focused with were drug cost savings through maximizing medication utilization. And in order to execute those programs effectively, we all know that the pharmacist has to be at the forefront, working hand in hand and directly with P&T committees and with prescribers at the time they're prescribing, so that we can make sure that we get a handle on that. Mike gave a great example of that with high-cost medication in the ED. And again, you'll find these all throughout the hospital, and if we found a large success rate and really effective decrease in drug costs when the pharmacists are an integral part of making those decisions and working hand in hand with the prescribers. Looking at HCAHPS scores, health systems everywhere watching these closely. Anything that can impact their reimbursements, they're really watching. And this is another metric that we've seen health system leaders actually measure pre-implementing, a hybrid model by leveraging remote and on-site, and post. Looking at improved interventions. Whenever we see increased interventions throughout a hospital, that typically means that automatically will typically drive a reduction in, of course, preventable adverse drug events. It can drive a reduction in duplicate therapies, et cetera. Of course, readmission rates are something that hospitals are really focused on, and employee satisfaction and employee engagement. And oftentimes when we talk to different hospitals that are challenged in implementing new initiatives and aren't sure how to create a staffing model to accomplish that, one thing that's key is they always want to make sure that they can retain their highly clinical staff. But what's interesting is post-implementation of a combined kind of remote on-site model, we've heard a lot from different leaders that say, we didn't really anticipate this to be a benefit while we hoped, and this was similar to what Mike commented to, but our voice of the employee scores have actually improved, and then employees were felt very satisfied in that senior leadership actually took into account their work-life balance, knowing that they needed to implement a lot of additional projects and work, and didn't expect them just to be able to do that with the existing staff and to be able to do that effectively and safely. And so I know, Mike, you pointed out, even on this slide, really a key learning, and I think that, it goes without saying, and if you want to speak to that.
Sure. A couple things a couple key learnings, I think, and just having a couple as I'm listening to you talk. So a couple was, as you present and develop the business plan, in my opinion, know your stakeholders. For some of you, maybe it's just presenting this to your boss, but some, maybe it's a committee. Each sort of culture is different. But know those stakeholders. Know what's going to be most important to them, or an aggregate of different information, and do some grassroots and make sure some of your other maybe key partners that could help you build this are important. Like for us, our ED kind of has a lot of authority and power within our organization, and getting them on board and supportive of something that you want to do is very critical to be an advocate for these types of things. Another thing I would just, and Kelly just kind of touched on it, and for all of us, third shift staff are probably one of our most, people that we don't want to leave the least, right? So they're so critical, and retention is so important. So doing, whatever you can, I think, to kind of retain them is very important. And then lastly, one of the things I left out, and my apologies, is that a year later, as one of the things I mentioned, our plan was to implement our own FTE after doing this for a temporary period of time, right? So our plan initially was to use the remote services for a year, budget for the 2 FTEs the following year, and off they go. However, because we engaged our third shift pharmacist, as we were starting to think about our budgets, strongly felt that they didn't need the additional FTE, and that the current model that we implemented of the hybrid model here with the on-site with the remote was adequate for our current volume and clinical status. So first of all, I was really proud of them to do that, and the maturity was fantastic. But it sort of highlights that our plan did sort of change also.
So I want to transition it over to the audience for some questions, but Mike, if it's okay, I would like to just ask you a couple of questions as well, just as a follow-up to what you presented today. And one would be, we looked at several metrics and we looked at your approach. Do you think there was a primary driver in your conversation with senior leadership that really made the business case most effective for bringing in a remote model?
Yeah, so Kelly, I touched on this, I think, a little bit. Our senior leadership team has a clinical heavy side now. It changes And by looking at that benchmarks, it was easily apparent to them that they don't want to be twice the norm on the wrong side. And as they were thinking about increasing, staffing maybe in other areas, such as mid-levels and stuff like that, and they kind of come to realize, you're telling me we only have one pharmacist? So, you get in front of a bigger committee, and sometimes you see the eye-opening for them, which was kind of the same thing for us. I mean, looking back on this now, one of the things I wish I could have done is I wish I could have done this, 10 years ago. That's the thing. They were living in that high volume for a long time. So, I feel partly responsible for that. But it became apparent to them that, all these core measures that are tied to pharmacy, like, stroke turnaround time and all these other metrics, and, one person can't do it all at a facility our size. So that was really the key takeaway is that benchmarking and showing that we were on the wrong side of the bell curve.
Right, gotcha. And for hospitals considering looking at alternative staffing models that could include remote pharmacy partners, are there any key capabilities or characteristics they should look for in a remote partner that you found has driven success in the model you've implemented?
So when we were vetting potential partners, I think some key things that were important to us were first and foremost, quality and safety is number one. Sometimes not the easiest thing to do to vet that with a partner, but bandwidth was important. Did they have the capabilities to take on our scope? Did they have the clinical expertise to do that? What kind of flexibility in hours did they have? Could they expand? Could they retract relatively quickly? As I talked about, this became our burning platform. So really, once we had financial approval to move forward, I wanted it the next day, right? So what was very important to me was how quickly could somebody turn it around and turn it around safely and effectively. I think other customers that are using that person and what they report. Those are important capabilities. And I think, what does it look like with this partner once you're on board? What are the regular quality calls? What are the metrics they provide back to you? What kind of things do they do to ensure that their team maintains competency and education and stays on top? Because as a level 1 trauma center and a big academic medical center, we have a lot of complex orders. So we want our partners to be able to do that. And I guess lastly, for me, whenever I vet a vendor, does it feel right? And I know that's not scientific for some, but does it feel right? Is this a partner or is this a vendor? And I want it to feel like it merges with our culture, and it's somebody that we would want to be partners together. So hopefully that answers the question.
No, it sounds good. Thanks, Mike, for elaborating on that. At this point now, Emily, I'd like to turn it over to back to you to facilitate audience questions. I see we have several coming in and would love to get as many of those addressed as we can.
Thank you so much, Kelly. So I'll jump in here to direct some questions from our audience. Just as a quick reminder before we get started, to our audience, you can submit questions by typing them into the Q&A box on your screen. And with that, we can go ahead and get started. This first one, I think, Kelly, maybe you can start with this. How would you address staffing in a small rural entity where all the regulations and standards are expected to be implemented, but there's no room for adding staff to handle all of it?
Yeah, and we see this quite often, actually, in the world of remote pharmacy. And again, the small rural hospitals have they don't get a pass on any of the regulations or accreditation standards that the large ones do. And so, in fact, bringing in a remote team is typically highly cost-effective solution. I know, at least in our world and in our experience, we have many small rural hospitals where there may be one pharmacist, and that's the staff, and that person is also the on-call pharmacist. So having that remote team back you up, if you will, which they can do 24 hours a day or just during set hours, again, is something that helps improve safety, The remote team can be called upon to do just about everything but actually dispense, and then they can actually engage whoever the on-call pharmacist is at the rural facility should there need to be an on-site presence or for something to be physically dispensed. But what's really beneficial about leveraging a remote-type staffing model for the smaller hospitals especially is that those smaller hospitals, rather than bringing on FTEs, they literally just pay for what they need. And so oftentimes the order volume is typically not that high. And so paying for a remote team to process 300, 400, 500 orders a month is certainly a lot more cost effective than having to bring in multiple FTEs just to be there to cover the hours, that are needed in order to provide, 24/7 care. And so we see this a lot amongst the smaller rural hospitals. And again, it is something that then yields them to be able to compete and be, ensure that they're compliant with all the different regulatory and state and accreditation standards.
Excellent. Thank you, Kelly. Mike, I just want to give you a chance here. Is there anything else you'd like to add?
No, I think I don't have a ton of experience in small rural hospitals, so I think Kelly probably answered that one as appropriately as I could.
Okay, excellent. I think this next question would be a good one for you, Mike. Can you talk a little bit about what your productivity metrics are and how you compared apples to apples?
So in our benchmarking for this purpose, it was strictly order volume and verification of the orders turnaround time. And we looked at them, so in looking at, we looked at the third shift and the number of orders they were doing and number of orders per hour, and then also the turnaround time. And as I mentioned earlier, there were pockets of, especially in the early mornings between 5 and 6:30, the times were doubling because there was a combination of things going on at that time. We mix a lot of the surgical irrigations early in the morning, and they're involved in verifying all those preparations, and they can't be in two places at once. So those were really the two key metrics that we used for the building of the business case, which was the order volume and the order volume, the verification turnaround time. And for some of you who may use Epic, there is some capabilities of kind of seeing what that looks like across the Epic platform too.
Excellent, thank you. And you mentioned this a little bit with the order volume and the verification turnaround time, but can you just elaborate a little further? How do you gauge what type of data is best to present for a specific business case?
That's an art form. So part of it is, so to me, and sort of goes to my residency leadership rotation, but it's actually developing relationships with the senior leaders and the ability to know their styles and what they're looking for and what they're going to focus on. That's the key. So, for example, in presenting this business plan, it was to our president of our medical staff, who's a physician, our CFO is an accountant, and then an array of sort of other people. They're kind of the two key people. And, I've gotten to know them both, and one is strictly going to want to know the numbers, and the other one's going to kind of go on patient care. But even before you present the business case, just be curious and say, hey, I have an idea. How do you think this would, resonate? People are generally more than happy to give you their thoughts on an idea you might have. So, we had just presented numerous business plans over the years. So I kind of have done it a few times. But knowing people, knowing their styles, and developing a relationship with them is key. But also, as a pharmacy leader, you're not going to get every business plan approved right away, and you have to be okay with that too.
Yeah, and I think
absolutely.
To add to that, Mike, I could not agree more that really understanding the priorities of the audience that you're presenting to, but also it's critical to align metrics to the particular goal you're trying to achieve. So if your goal is to reduce 30-day readmission rates, right, then you're probably going to look at other metrics that will define and let you know how you're performing against that goal than you would if you're looking potentially at, I want to reduce drug costs. So I think, again, it's very key to make sure that just align specific metrics that can then speak to and provide you a good baseline and then post-implementation measure. I do think metrics should be measurable. One of the challenges that we often see when we work with our health system leaders and pharmacy leaders is sometimes it's difficult to achieve a baseline. You know that you're struggling with something, but just getting the data to prove that you're struggling can be difficult. And so I know we often, too, try to work with our leaders, even if it's manually compiling information initially to get a baseline. I do think that's important because, especially as you continue to ask for investments, showing that you've proven your business case and that you've proven, you know what I mean, what the success rate is that you want through the metrics that you've established will be really important.
And Kelly, just to add on, I think I would just say totally agree, and I think for your audience potentially, if it is a committee, and so in my experience it's a group of people, and the strategic goals of the organization, you kind of know which ones are most near and dear to each individual, so you kind of try to gear your business plan to tackle each person's, I guess, most important metric, if you know what I mean, if you can. That's in the perfect state.
Excellent. Thank you both. That was really helpful. This next question I'll send over to Kelly first. How do you ensure the off-site pharmacists are up to speed on policy and process changes?
That's a great question. And I think, you know, and I know, Mike, when you were speaking earlier about key characteristics and capabilities of the remote partner, I think that this area is one that should not be overlooked. It's critical, and we all know that the off-site pharmacist would process orders according to the same policies and procedures that your on-site pharmacist should. From a nursing perspective, the way orders are entered should be completely seamless. Nursing shouldn't even recognize that, you know, the person that's entering these orders is on-site versus off-site. And so there's technology, at least, that we can speak to that actually obtains all of the hospital's policies and procedures and then enables keyword searching for the pharmacist literally real time as they're processing orders. And then in addition to that really policy and procedure oversight and reference, if you will, for the remote pharmacist, anytime a policy and procedure changes, and we know they often can, making sure that the pharmacy leader at the hospital actually has a mechanism to provide those updates to the remote team, and through technology the remote team can be automatically alerted when a policy and procedure changes. This is an area that I can't stress enough. We often see this, especially with large health systems that implement an internal kind of remote or centralized remote order entry service. And sometimes the variation in policy and procedures across all the sister hospitals, even if they're all a part of the same system, I think kind of is underestimated. And we've received that feedback from some large health systems that have implemented kind of a centralized internal remote team, that they really underestimated the variation in policies and procedures and lacked a mechanism to efficiently provide that P&P information to those remote pharmacists as they're processing orders. So I think just making sure there's a mechanism in place and understanding what that mechanism is, really challenge and talk to the remote provider, whether it's internal remote provider, internal to your system, or an external service provider.
Thank you, Kelly. And Mike, do you have anything you'd like to add to that?
Yeah, I think, first of all, I think that's a fantastic question, because when somebody's not, you can, see every day, you wonder about that. I would say how I would answer that is we hold the remote service pharmacist accountable for what they do just like anybody else. And I expect the same quality and outcomes from that individual as no different from our own individual. Now, how you do that, obviously there's some challenges too, but for us, obviously there's a person on site so they can talk to each other. That improved collaboration between our on-site person and that person, so they get to actually bounce ideas off each other and vet clinical things. Because sometimes when you're all by yourself, I was once many years ago a a night pharmacist, and it can be kind of scary at times. So having that additional person to vet that off of is fantastic. But our day pharmacists will catch things that they may think of should have been caught on nights, whether it be our own pharmacist or the remote pharmacist. And we bring those to the attention. They bring those to attention of me and my leadership team, and we talk about that. And I would hope that your remote partner takes them just as seriously as yourself and makes efforts to educate and maintain a high level of competency. I think it becomes relatively apparent to you the competency of the person working in your system because you're going to see all that stuff the next day. That's kind of how I would answer it.
Absolutely. And as a follow-up to that, to what extent did the remote pharmacist participate in clinical pharmacy activities?
It's a good question. So, I mean, the purpose of us strategically having a remote service was to offload that huge order volume from our current person so our current staff could do a little bit more of the high-level clinical. So we do operationalize things a bit different. So there are certain high-cost drugs with kind of a little bit more, difficult policies, and we do consults and progress notes, and we do have our on-site pharmacist doing that, and the remote person focusing a bit on the order entry. However, to me, verifying an order is the most critical step in the process, and if you don't vet all the necessary information to ensure that that patient gets the right med and has no bad outcomes from it, that's really the key. So to me, all pharmacists are clinical. So verifying orders for our facility and making sure that those drugs are effective, they're the right drugs for the right patient, those are all important clinical activities.
Absolutely. Thank you so much, Mike. So those are all the questions we have today. I would love to just give Kelly and Mike a chance if you have any closing thoughts you'd like to share with our audience.
Sure, I'll begin.
Kelly,
First, I just want to thank you, Mike, for working with us and presenting, the specific challenges that you faced and kind of what your approach was into evaluating different solutions and the solution that you implemented. And I guess I would like to end it with that. As we look at, again, just going back to the key trends that are impacting pharmacy, a lot of health systems historically had adequate pharmacy staff, and leveraging a remote team kind of in a hybrid type workflow just wasn't necessary. But now, with the landscape as it is, and a lot of new initiatives being, critical, transitions to care programs being critical, one of the things that I continue to hear from a lot of our health system leaders is that, in the past, I could just focus on what happened to the patient while they were within the four walls of my hospital. But today, based on reimbursements and Medicare bundles, I now have to focus on what happens to that patient even when they leave the hospital. And in order to be able to do that, again, the pharmacist is such a key skill set in looking at programs that can ensure adherence and that ensure greater outcomes, especially once the patient leaves the facility. So, again, just because traditional staffing models may have been effective in the past, there's a lot of hospitals out there that are looking to doing creative staffing models, just like Mike, that they found, not only can be more cost effective, but again, really help them align with what their key goals are and achieving those. Mike?
I don't know if I have it. The only other thing I'd like to add is one of the things we didn't talk about is because I had mentioned that our smaller facility that is our sister facility had been using remote service verification prior to us. One of the, benefits that we had that I didn't expect was because of the model that we implemented, we actually reduced their costs because their volume's relatively low, and they were paying per order, and by moving over to the model that we had set up, we reduced their costs relatively significantly. So that was an added benefit and cost savings for our sister facility that we did not expect. The other thing I think for us, that we have remote services across 2 organizations now is, and we're still relatively new organizations and knowing each other, there has, I think, this partnership between ourselves, our sister facility, and Cardinal has helped us with our integration and regionalization efforts a bit in identifying things where there's maybe variation, and now we have sort of a common platform. So.
Excellent. Well, thank you so much, Kelly and Mike. That was an excellent presentation. And thank you to Cardinal Health for sponsoring today's webinar. To our audience, please enjoy the rest of your day, and we look forward to having you join us for future webinars.